Good morning, everyone. Good morning, and hello. Okay, good morning, everyone. Thank you for coming to this innovative session we have developed for this IPSO-EC Congress. It's called the Shark Tank in Bariatric Surgery. It's a little bit innovative for us, so I will try to explain the structure of the session. My name is Amador Garcia, I'm bariatric surgeon here in Spain, and we designed a session where we are going to discuss 3 topics: CDS, ileal surgeries, and ESG. For each discussion, we will have 1 moderator, and 1 discussant, and 1 judge. The presenter will have 10 minutes for explaining the technique, the rationale, the results, and the evidence behind this technique. After that, we have the judge that will discuss the presentation and the data presented for around 5 minutes. And for every single presentation, we will have a fact checker, who is going to be Professor François Patou, in order to warn if the data or the argument are right, are not right, maybe biased, or whatever. Every session, every topic will have a moderator. For the first moderator will be Professor Mot Rubert. For the second moderator will be Professor Kelvin Hiva, and for the third one it will be myself. And the moderator will try to guide the discussion and also open questions to the audience. So, whenever you want, Mot, we are going to begin with the first one.
It's my pleasure to call Andres Sanchez, who don't need any presentation. So, Andres, it's your turn. So you're speaking for us to the study.
Thank you very much. Thank you very much to all moderators and to Amador, of course. So, if I understand this well, I have to sell you a product, and you will analyze if the product is okay or not. I think we have not experience on these TV programs in Spain, I think, but I've seen something of your American one. I think this product is already sold, because I read last year in the Washington Post that, what is this? New surgery leads to more weight loss than Q&Y gastric bypass and Ozempic. And this is all, but this influencer, this American influencer that was submitted to the operation. So the product is already sold. You all know that this induces more weight loss than Q&Y gastric bypass, so it will be all I have to say. But I will try to review some of the literature about this. First, some of the history of the technique. It was presented first time in a congress, in a meeting in Capri, in the 3rd Congress of IPSO-EC. And I had the opportunity, it was then called Loop Duodenal Switch, no series. And I had the opportunity to present it, and the moderator was Malfovi. And he just asked me 1 question. He said, do you close the retroanastomotic space? And I said, no, it's not necessary, it's too huge. And he said, you have to close it. And I said, no, it's not necessary. You will be taken to court if you don't close the mesentery space, because the retroanastomotic space, because you are expected to have 14% hernias. 20 years later, I have no internal hernias. Well, the aim of this operation was first, to reduce the technical difficulty of the duodenal switch. Second, to maintain the advantages of an anastomosis to duodenum when compared to a gastrojejunal or gastrointestinal anastomosis. And then to maintain the power of a hypoabsorptive and metabolically oriented operation that was the Q&Y duodenal switch. 20 years later, I think we have seen that the operation is easier and faster, is safer, because there are many people doing it as a same-day surgery, discharge. And we have to demonstrate also the long-term quality of life and safety that have improved when compared to the Q&Y duodenal switch. This probably is the most important paper on duodenal switch, because it was written by the author, Hess, in the mid-90s with the experience of 10 years of duodenal switch. And these are the results in weight loss, about 70-something excess weight loss at 10 years with a very, very good follow-up of more than 90%. And the numbers of complications were also quite low, as you see. And which are our results? These are results after 15 years. Don't consider the higher results at the end of the graphic because they correspond to patients submitted to studies 2000, so it's a bit biased. But as you see, the total weight loss is about for 38% at 15 years from surgery, which is not bad. And if you see the complications in the initial series, well, we had a couple of leaks, one gastric staple line leak, one perforation of the small bowel. So I think they are comparable to what you have after a Wen-Y gastric bypass and much better than what we had with the Wen-Y duodenal switch. Everybody is concerned by malnutrition. And what happens? Well, our malnutrition rate in the whole series is about 3%. But if you see this graphic, you see that from 2019 to 2026, only 2 patients have been reoperated. I mean, patients submitted to the first surgery in last 10 years, only in 2 cases have needed reoperation for malnutrition. So the real rate is below 1%, the real current rate. This means that we have had to learn how to do the operation, how to select patients, and how to supplement them, and how to follow them to reduce this rate to the similar to Wen-Y gastric bypass. In studies comparing Wen-Y duodenal switch to one-loop duodenal switch, we can see a varied number of weight loss attending to both types of surgery. I mean, in some studies, as this by the group of Belvice, at 2 years, both operations behave exactly the same. But when the authors study the same series some years later, they see that patients submitted to study S have a poorer long-term response than patients submitted to Wen-Y duodenal switch. What's the difference? Most of the patients submitted to these operations in this institution have the study S with a 3-meter common limb. And in our own experience, there's a difference between both operations. Here you have results at 10 years comparing 250 with 300. So I think 300 is a different operation to the original Wen-Y duodenal switch. 300 is safer, but it's closer to a Wen-Y gastric bypass and not to a Wen-Y duodenal switch. So I think we should offer for our patients, if we want the same results, 250 as the distance of the length of the common channel. In this study from the United States, from the group of the Mayo Clinic, you see that the results are much better or are slightly better after study S than after duodenal switch. That's a bit difficult to understand because the same group finds difference in the Wen-Y duodenal switch and study S when different type of patients are compared above or below 50 of BMI, preoperative BMI. But what this demonstrates, this is a Spanish study also with another institution in the United States, the group of Teixeira, and then they have slightly poorer results than the other reported by the group of the America. Perhaps this is a group of patients submitted to different type of operations, and we cannot put all them together. This is very interesting, but because this can explain some of the things that we are saying. Is the study from the group of Porto, from Ana Marta Pereira, Mario Nora, and Marta Guimaraes, that they demonstrate that there's a difference in the weight loss after study S attending regarding the length of the biliary channel. So they demonstrate that from with every 10 centimeters that they increase the biliary channel, there's a 0.3% higher rate of weight loss in the long term. So we have to think about this for the future. So to conclude in this comparison, results of both operations are similar. Probably the duodenal switch with a 100 centimeters common limb is comparable to studies 250. We have to demonstrate yet if the same operation works similarly on all BMI subgroups. It seems that duodenal switch is followed by more nutritional issues and less quality of life in the long term. We have to attend to the study of Ana Marta Pereira about the length of the biliary limb. And a final conclusion is that both operations are quite similar. If one is easier and works somewhat better in terms of nutritional issue, I think that's the one we would have to do. And some comments about the comparison between SADIS and Wen-Y gastric bypass. We have to follow this guy, Dan Cotham, who I think he's the the surgeon with greatest experience in the world in SADIS. He started doing 300 with Mitch Rosling, and he had this comparison, this retrospective comparison, but he made a propensity score matching two comparable series between Wen-Y gastric bypass and SADIS and published it in 2020. As you see, results show that SADIS obtains a better weight loss in the long term at 5 years, and still what is remarkable in this paper is that complications are not greater after SADIS than after Wen-Y gastric bypass, nutritional or reoperations. We have our own results. We compared patients submitted to SADIS and Wen-Y between 2009 and 2013. We matched them by age, gender, weight, and BMI. And these were our postoperative complications, a bit higher in SADIS, but not significantly different. This is the quality of life and problems in the long term. More diarrhea, 25% after SADIS, similar vomits, no problems with the anastomosis, no dumping, and 8 patients out of these 60-something had gastroesophageal reflux. And differences in weight loss, you see them here. SADIS outweighs Wen-Y gastric bypass by almost 15 points of total weight loss. And of course, we have the paper by Maud that demonstrates finally that the operation is not only comparable in terms of complications and long-term quality of life, but superior to Wen-Y gastric bypass in the short term, at 2 years from surgery. These are the graphics that demonstrate this data, but I think Maud could comment better than me all the results. The operation is equally safe. Reoperation numbers are low in both groups, similar, comparable. Readmission rates are comparable, so SADIS is as safe as Wen-Y gastric bypass in this prospective trial. This was also demonstrated by the group of the Netherlands with SADIS as a second step, or Wen-Y gastric bypass as a second step. This is a prospective non-randomized trial, but demonstrated that weight loss is much better after the hypoabsorptive operation. And what is important in this paper is that they demonstrated that they had no more nutritional issues after SADIS than after Wen-Y gastric bypass. If you see the graphics here, you see that patients submitted to Wen-Y gastric bypass as a second step or as a weight recurrence after sleeve gastrectomy, in the end, they achieved the same weight that they had before the operation. So it's an absolutely failure, if I can say again. So to conclude, I can affirm today that SADIS is more effective than Wen-Y gastric bypass in terms of weight loss without causing any adverse nutritional effects. And a greater number of patients are going to experience diarrhea and reflux. But we are starting a new randomized trial in Spain, multicentric. This is the preliminary paper explaining the trial, and I hope in 5 years I can give you the results of the Spanish trial. Thank you very much.
So the judge is Nicolas. Lorenzo? Nicolas?
Well, you know, as always, Andres is a great scientist and a gentleman, so he gave a presentation, a very balanced presentation. But if we want to be too polite, maybe it's not the sense of the session. So I say that I am playing with Zidane, but I am Materazzi. So I have to do something, not to contrast, but to say you made an excellent presentation with many comparisons, demonstrating things that are very clear with your long experience. But my question is the following, because you mentioned the patient that you reoperated because of the main complications in terms of nutritional complication. My question, and for example, for the studies leave that you mentioned by mode, after 2 years, the albumin is the same. But the question is the following. We now know the data, and will be published the data at 50 years by Francesco Papadia concerning the BPD. It's a different story. I know the duodenum and so on. Are you afraid of what will happen in 30 years in these patients? And in 50 years, I mean, it's a follow-up. It's impossible for any other procedure, I think, apart from for some lost operations. Are you afraid that through the time this will happen, or you think that the stable results that you showed will stay for the following years, because you operate also on young people?
Oh, thank you. Thank you very much for your comments. Of course, it's of a concern, this. I think when you start a procedure and you do not know really what is going to happen, you should be concerned precisely because of these young people that have many years on to have problems or issues with the surgery. Well, we have studied the Italian experience of Nicola Scopinaro and the American experience. Nicola presented 30 years results and were safe. I know that Francesco has demonstrated that there are more issues with the passing of time. And precisely, patients, in our experience, patients suffering from problems in the long term are those who were older in the first surgery, or we can say frailty, perhaps. So we have to take care in the selection of patients. If you do not do the operation, the 250 centimeters common limb operation to patients older than 60, to patients with lower BMIs below 40, to patients with a special liver or intestinal disease, they are going to be very safe. So it's a matter of preoperative selection and choosing between one or the other option. Evidently, if you have any doubt, you can go to a Roux-en-Y gastric bypass. But results after studies are more homogeneous in the follow-up than after Roux-en-Y gastric bypass. Why? Because Roux-en-Y includes many different operations. And studies is the same, 250 or 300, but it's the same.
As a judge, I must say that you answer very well. Second point is the following. Because this is a hyperabsorptive procedure, by definition, do you think that the follow-up of this procedure is really what we should be, or even in your experience, and now there are several people, especially in Spain, I know that there are groups doing a lot of studies, that the follow-up is satisfactory, or still you lose patients, as is the experience of all of us, losing too many patients. Just to mention something which is out of this, we have a good registry in Italy, but after 2 years, we lost more than 50% of patients at follow-up. Is it the same for the studies, that this is a concern for you?
Oh, yes, it is. At 5 years, we're able to follow about 80% of the patients. At 10 years, we go down to 55%, and at 15 years, it's much lower. So it's an issue. So we have to improve this aspect.
And concerning follow-up, what is the strategy? Do you perform endoscopy, for example, for the bireflux, or do you have a standard for apart from the nutritional part, of course, you have a standard for evaluating the procedure itself, the surgical part?
Yes, all patients are discharged on PPA therapy, and they are kept on PPA therapy for the first 1 year. After the first 1 year, we do upper GI endoscopy to all patients, and if no special findings, they are followed as every patient, if non-submitted to bariatric surgery, just symptomatic. We try to follow the guidelines of IFSO, but this is the general follow-up that we do.
And if you have bireflux?
Huh?
If you have bireflux?
If bile reflux is symptomatic and you demonstrate it with scintigraphy, with Bilitech 2000, and the patient is really bad, you convert into a Roux-en-Y duodenal switch with a short alimentary limb of 50 centimeters or 70 centimeters.
So the follow-up, in a sense, is also including the sleeve, because the sleeve, we know that can increase the problem. What is your experience on Barrett findings in these patients in these 15 years? Do you have cases?
Cases with?
With Barrett esophagus, because of
Barrett esophagus? No. We have reviewed about 160, 180 endoscopies, and we found, I think, one case of Barrett's esophagus that it was preoperatively. So we have not found the novel Barrett's esophagus.
Great. Now, I said that I'm a Materazzi, but I also want to be more polite and give you the ball. What about the technique that is being developed by many people, cutting the gastric artery or not cutting the gastric artery? We were discussing. I have to disclose that we spoke about this 5 minutes ago, but I think it's an interesting issue, technical issue, because we only speak about follow-up, while also the technical aspects are interesting.
Well, they are not to be criticized because I should not say that it is easier, the operation dividing the artery. It is easy to do the anastomosis, but sometimes to divide the artery is not so easy. I mean, you have to have experience in gastric cancer surgery to do it properly, to do it well, so it's not so easy. But it's not necessary. We are trying to demonstrate that the division of the artery also divides the vagal branches of the hepatic plexus to the pylorus and could affect pyloric motility. But we have not yet demonstrated it. We are trying to monitor it intraoperatively with the same sensor they use for the thyroid surgery, and we will see. I will tell you next year.
My question is, while I put the question, I was looking at Gerhard Frager, because I'm pretty sure that he has some comment on this. So, last question is, do you think that magnets will kill the operation?
No. No, I don't think. We tried with Michel Gagné the magnetic bipartition, and it is all right, but I don't think it's necessary. One anastomosis that takes 15 minutes to perform, and that's have less than 1% complication rate, I don't think is going to be substituted by magnets. Because magnets are not yet developed enough to permit the one anastomosis technique. They permit a bipartition. And, well, I don't think so.
So do I.
Okay.
So that's it.
Yeah, thank you, Nicolas. So I will give the microphone to our fact checker.
Yes. So thank you very much, Andres, for this interesting presentation. I'm the fact checker. I'm the bad guy. You see the show on the TV? It's a bad guy. So I thought it was not too difficult, but I saw many points. I would just focus on one. One thing is I said, good start. Good start. You showed us a surrogate early endpoint, weight loss. But this is a new landscape. The new landscape is we are dealing with a chronic disease. We need hard clinical endpoint. And my question is that we don't know if this way of getting a little bit more weight loss is going to be good. Just remind us, diabetologists 30 years ago, they were just super happy because they were decreasing A1C, much better with insulin. When I was a student, it was insulin everywhere for type 2 diabetes. And 10 years later, they just discovered that they were killing patients from their heart. My point is that we have to be careful. My experience 30 years ago with ileal surgery, which I did with my boss a long time ago, it did well. I'm not talking about many things, diarrhea, all that. It's another story. But just about, do you have any fact that shows you that you're going to do a better job in increasing life expectancy than gastric bypass? I doubt. I don't know, but I doubt. No one showed that with Scopinaro study, with Scopinaro operations. You do better than nothing, of course, but the drugs are there now. So be careful. So what is the fact you think that you're going to do better things life expectancy-wise?
Well, regarding the first argument that you said, that we have not to be oriented towards weight loss and just to the treatment of comorbidities, I think we have to admit that if the patient does not lose weight and does not maintain this weight loss, is not going to have any benefit on comorbidities. That's true. So if the patient gets more weight loss, probably the benefit is going to be higher. There's no demonstration in the paper by Mo that patients submitted to SARIES have more benefit in terms of diabetic remission or diabetic improvement. And probably both operations work quite well, but at 2 years, it's not enough to say that the UNY is going to achieve the same results of the SARIES in the long term, because at 5 years, 30% of your patients submitted to UNY gastric bypass are going to have weight recurrence, and probably diabetes will run parallel to this weight recurrence, while the rate of weight recurrence after SADIES at 10 years is just 9 to 10%, and that's a huge difference. And this goes in line with the improvement in quality of life and length of life.
Good. But just remind all of us, our field has one target. It's SOS study 2007. Changed everything, changed the world for us. We didn't see it because we were already with the weight loss and excited by that. But for the other world, life expectancy increasing, that was never seen before. It will never happen, very rarely with drugs. I think we'll see, but we'll see in 2 decades if it appears or not. But I think that for surgery, we need to be careful. Chronic disease, good outcome. And I think we'll see.
We'll see.
Don't be too fast. Weight loss is good, but too much in any way can sometimes be worse. So just my fact. Be careful, aren't clinical endpoint. We need that.
Follow your advice, of course. Thank you.
A last question to you, Andres. You showed us that in Capri, you tell Dr. Phoebe that you were not closing the mesenteric defect. And we saw on your data at the long time that you had hernia.
There too?
You had hernias, internal hernias. So do you close now the mesenteric defect?
No, thank you very much. No, I think never. Only we did in the study that we did with Michel Gagné, because he insisted that the operation should be the same as he did, and so we had to open the mesentery and the omentum and close the retroanastomotic space. I think it's not necessary. We had one case, and probably has been published somewhere, that the patient appeared to have an internal hernia and was reoperated. The surgeon who reoperated that patient never could tell that it was an internal hernia. There was a patient in waiting list for lung transplant, was on oxygen therapy, and all the small bowels and the great bowel was dilated, so it was very difficult to know if that had happened. Could be. But I have reoperated some patients in the long term, 15 years from the first operation, in which I have found the small bowel totally twisted, as in an internal hernia, because of an anastomosis with the twisted initially. And the patient had no symptoms in all his life for this problem. So the small bowel, you could see it going into and out from the space without problem. So I don't think it's important. I don't think, but it's our experience with 700 patients in 20 years.
So last questions from the audience?
Question.
Andreas, how do you explain that the operation, although well studied, well designed, hasn't grown up very much in terms of numbers? The centers worldwide that do the operation as a first line or revision operation are limited. How do you explain this?
Thank you, Louis. The only possible explanation, the first issue that people were concerned about was malnutrition. When you explain how malnutrition works, in which patients presents and so on, there's no problem with that. Many people say that it's the dealing with the duodenum. I don't think it's a special issue to dissect the duodenum and do an anastomosis, but probably many people, if you offer similar operations with different anatomy, as can be the OIGB or the SASI, instead of the SADIS, as results are quite similar, they go to the easier operation. I always say that one thing that happened in my hospital, we had a group of people from Colombia visiting us, and they stood for 2 days seeing SADIS in my hospital. And they went to Miguel Carvajo to see OIGB, and they went back to Colombia and they started OIGB and not SADIS. So when they see that the operation, there are possible operations much easier than this with comparable results, I understand that they go to the easier operation.
Last question?
Yeah, I have a question.
You're defending well, eh? You're defending
I have a question. Hello.
Amador, you look
Hi.
like France.
Hi, Andres. Nice presentation, nice defend of the technique. But in any case, we know that every duodenal switch, every SADIS we perform is previously done a sleeve gastrectomy. So wouldn't it be a good idea to do a sleeve gastrectomy to all the patients, and then those who fail, then propose to convert to sleeve gastrectomy or SADIS? And that's all because first, we do not know what patients, maybe they have more chances or not, but we don't know what patients are going to respond just to sleeve gastrectomy, which is more physiological and less aggressive.
Yeah, thank you, Juan. That was an idea, I think, proposed by Mitch Rosling, and it depends, of course, on who is paying for the operation and how many operations are you going to be paid by. I mean, in Spain, we have no limit, so we could do that policy, operate every candidate sleeve gastrectomy, and then 40% you reoperate on them. If they have reflux, 10% will go to one-way gastric bypass. If you don't have reflux, you go to 30% SADIS. So instead of having, say, 60% of the patients undergoing SADIS from the first moment, you have only 30%, and all patients are going to have succeed the operation, any operation. Sleeve gastrectomy, less problems, less complications, less follow-up, less supplementation, and you will still have 40 to 60% of patients with this surgery. Yeah, that's a good idea, but depends on who is paying and safe.
Thank you. Good define.
Thank you.
We are running. Okay, sister?
Yes,
Okay, sorry.
Rui,
It's very brief.
So last question.
Andres, coming back to the magnets, you have a good experience with the duodenal bipartition with magnets by Michel Gagné, okay? The late permeabilization. But you know that GI windows, you can do the immediate SADS, like Mandari and Galvonet are doing. And don't you think that for the people that are not so comfortable with SADS and duodenal management, it will make your surgery more sexy, more fancy, and they can do it with magnets more safely?
Thank you, Rui. I don't think the anastomosis is difficult. And I think all bariatric surgeons now are able to do this anastomosis with a very low rate of problems. I think, for me, it's more difficult, the GJ anastomosis, than the duodenal anastomosis. But it's a personal opinion, Rui.
It's a myth, but the Colombians went for OGB.
Thank you very much.
Thank you.
Let's go. Okay. And we'll bring up our next contestant, Gerard Prager. Hope you have something interesting to sell us. Nicola, I did not. Are you going to buy this company? Are you convinced enough to buy this company and this? The SADS. Only part of it. Okay.
So I won't sell you something because I don't do neither SASI nor transit bipartition. I'll do the opposite. I will put a critical light and tell you why I don't do it. I do all the rest of the stuff. I do quite a number of SADIs, but I always mobilize the right gastric artery. So when we look at the literature dealing with transit bipartition, of course, the most important name is Sergio Santoro. And his most prominent publication is this one from 2012 with 1,020 patients. And you see it's actually a sleeve gastrectomy and a gastroileal anastomosis with a kind of a BPD configuration. The total elementary limb length of this anastomosis is 260 centimeter, 180 centimeter elementary limb, and a rather short common channel of 80 centimeter. Keep in mind, the shorter the common channel is, the more it goes to chologenic diarrhea. You lose the enterohepatic cycle, and bile acids enter the colon. And when you look at the 5-year follow-up, you see 60%, and keep this BMI loss in mind. After 1 and 2 years, 91, 94%. Whenever you go with your excess BMI loss or excess weight loss close to 100%, this means that 50% of your patients have more than 100%, or in other words, excessive weight loss. But look at the weight loss after 5 years. It's from 94 to 74%, okay? Signs of malabsorption were rare. Important, the size of the anastomosis, 3 to 4 centimeters. When you go too narrow, majority of the food will go through the duodenum and only less to the gastroileal anastomosis, and that might also change with time. We don't know. Some authors claim that 60% go through the gastroileal anastomosis, 40% through the duodenum, whereas others claim 80% go through the gastroileal anastomosis and only 20%. But nobody really knows, and nobody really knows how it changes over time. And we don't have to reinvent the bariatric wheel. Keep this also in mind. And Santoro himself changed it 3 times. So also he had these fantastic results. This is a paper of 2020. Indeed, over the years, we had elongated the common channel 3 times, which means you increase the common channel, less side effects, less chologenic diarrhea, better enterohepatic cycle, closer to SADI-S. Other publications include this by Philippe Topar, very well matched duodenal switch with 71 transit bipartition. Again, the problem is only 1 year of follow-up, and I will show you later on why this is a problem. Khaled Arentaskin, he is here. 883 patients, low BMI, class 1 obesity and overweight. Follow-up rate 73.2%. Total elementary limb length, again, 260 centimeters, so very close to a BPD kind of operation. No protein malnutrition at all. Perfect results, but again, only 1 year of follow-up. Let's look at the SASI. Here you see the entire literature, and I'll focus on 2 papers. The first one published in 2016, and then the 10 years results. And SASI is a modification of the transit bipartition. And the real difference is that you have now the entire length, these 250 centimeters, bile flowing through. This means the enterohepatic cycle is working much better. You have less side effects, less chologenic diarrhea. And in this first paper, you see 61 patients mentioned in the abstract. In the paper itself, it's suddenly 67 patients. Only 50 were evaluated because some had a laparotomy and they excluded it. Follow-up of 12 months. Again, very important, 3 centimeter anastomosis, 250 centimeter common channel. 100% diabetes remission, perfect results, 90% excess weight loss, no malabsorption morbidity. Keep this in mind. And the authors conclude SASI might be the most appropriate metabolic surgery procedure today. And then the same guys published the 10 years data, and they claim that they include all patients who underwent SASI from 2013 to December 2015. But suddenly group 1 with 2.5 meter has a 4 to 6 centimeter anastomosis, which is different from the publication in 2016. And suddenly group 1 has a 60% malnutrition rate and a 40% reversal rate. And on top of that, you see that the group 1 consists only of 15 patients and not anymore of 61, 67, or 50 patients. And the follow-up rate after 10 years is an incredible, or they have to be congratulated on that, higher than 90%. Rui is in the first row. He published midterm results. Again, very good data, very good results. 2 patients converted sleeve due to protein malnutrition, but these are not real midterm results. And I'll show you why. Because at 5 years, we have only 12 out of 68 patients. So the end of the graph, maybe we should be very careful to evaluate. So my concerns is we don't know anything that is beyond, or any solid data that is beyond 2 years. But there are also papers that shed a malabsorption light on this procedure. This is a publication that claims 20.6% of malnutrition. and you see with a common channel of 250 centimeters. And another by Al-Wafa, same story. The weight loss is perfectly the same as in the original publication that had 90-point-something% after 2 years. He has the same weight loss, but he has a 20% reversal rate for the same operation. I have no idea why there are so different percentages of malnutrition with the same percentage of weight loss. Maybe we have to rethink it. And it is a certain degree or a strong degree of hyperabsorption. And when you look back, there was a lot of enthusiasm about the BPD, especially in Italy. And we did not hear much about protein malnutrition. And actually, it came from other countries. And I show you this paper. 9 patients listed for liver transplantation in Belgium. And it occurred in the majority of these patients. I can send it to you, Luigi, you don't have to make a photograph. After 1 year. The majority occurred after 1 year. Too much of a good thing might be bad, be careful. So we have a growing clinical literature with SASI and transit bipartition. The configuration strongly influences the nutritional risk, but we have no good data on that. And now I tell you what are my real concerns. You only have to be old enough, and you don't have to reinvent the bariatric wheel. Gastroileostomies have been done 60 years ago for duodenal ulcers, where the ulcer occluded the duodenum. And surgeons made loop ileostomies. The ulcer healed. What happened to the loop gastroileostomy? It shrinked, it occluded, and it closed completely in some patients. And this is my biggest concern about these 2 ways. You cannot predict how much is going which way in the future. SASI is an interesting procedure. This is the IFSO statement on innovative procedures in 2022, and not much has changed. However, it lacks validation, and the same is true for the transit bipartition. And we are all looking for our fact checkers, or also Maud is involved, transit bipartition, RCT from France. Brolin said the past returns in the future. Reinventing the bariatric wheel, what we know, thought we knew, and hope to learn. Keep in mind our enthusiasm about the VBG, the band, and maybe also about the sleeve. We really need to have at least sound 5-year follow-up data, and I don't see that at all for both procedures currently. Thank you very much.
Okay, so our judge will be Mauricio De Luca. I think Dr. Prager made your job a little easier, but I'm not sure.
Of course, Gerard disappointed me because I had to talk against bipartition, but now it's more difficult to do that. I prepared something against, but he gave me the way. Now, first of all, I want to say 2 things. We have only to date 3 trials regarding the concept of bipartition. We have the Azevedo Santoro 2019, comparing transit to the medical therapy. The second is of Sawefi 2025, which compares SASI with SAS-J. So you can say that there is a dishomogeneity. And now there is other 2, one from China and one from France. The China one is comparing transit versus sleeve. So we have not enough literature, as Gerard said, and what we have today has a high dishomogeneity. Another thing that we have in terms of dishomogeneity is the acronyms. Now in Italy, we are to try to identify literature in order to have good clinical practice, in order to practice transit bipartition. It's very difficult because in Italy the law is severe in terms of approval every procedure. We have to pass a grade 2 methodology, so it's not easy with this literature for us in this moment. But one thing that I want to point out is, and this is our fault,
is the dishomogeneity of the acronyms. Regarding, for example, the word of the bipartition, we have gastro-jejunal, gastro-ileal, duodeno-jejunal, duodeno-ileal, and we have duodeno-jejunal, duodeno-ileal with duodenum transection, without duodenum transection. Then there is the magnet who is pushing some kinds of procedures. So we have in this moment, in terms of finding papers, a lot of problems. Other consideration, but maybe Gerhard has already given the answer. Why, when we talk about BPD, DS, SADIS, we consider the concept of malabsorption, hyperabsorption, and when we talk about transit bipartition, we talk about GLP-1 plus, PPY, FDF 19, talk about metabolic surgery. Why do we say this? Why? I have not an answer. Because in both the case, we have the symptoms, the effect of a malabsorption. And we show it in the literature that Gerhard showed us. Other consideration, but Gerhard said that, we talk about of one anastomosis which give the possibility of food intake through the duodenum, 30%, through the gastroileal anastomosis, 70%. We don't know what happened. We cannot know what happened in this specific anastomosis because of technical details, because anatomical details. So at the end, why we have to talk this operation as an operation which is a metabolic operation, while the other operation that we should compare are called malabsorptive operation. And then the question I want to do together, but I cannot have the answer. Santoro, Sergio started 22, so 24 years ago. Why this operation hasn't spread a diffusion in Western countries? But maybe you answered already too.
I think a lot of people started, and as I showed you, some realized that there is a hypoabsorptive component that harms the patient, but you realize it maybe after 2-3 years or longer. And that's the reason why SAS-YOT came up. Because some people realized that the ileal anastomosis might be too much.
Yeah.
But I consider it still experimental.
I have also to say that the Indian study, which compares SASI to SAS-J, has the same weight loss and different malnutrition, but the follow-up is too short. We cannot consider it because it has not 5 years follow-up. So the problem is the literature.
Yes, I'm not sure who's a shark here or not, but Francois, maybe you can shed some light on the facts here.
Just to remind you, we are the fact checker because it's an important session, because you are investors. We are listening to start-upper. They are going to sell their operation, which is a startup, and you're just asleep because everyone says, don't forget this one. I would be careful. Never throw everything at the first sight. So I will not go to the French study because, of course, it's a bona fide study and it will be not disclosed. We will not disclose anything. I can only say one thing, is safety, because safety has been already analyzed and has been already diffused in a French meeting. So I can say few words.
But Francois, what do you mean by safe? That you have no perioperative morbidity?
I mean safety mean what was done in a bona fide study, which is, of course, there is a limit. It's not lifelong, but there is facts, and I will tell you. But first of all, little things, fact checker. I'm charged for the presenter. The big thing was 94% excess weight loss. Maybe more. No, this is not math. Excess weight loss is not a normal distribution. You cannot go below 100 easily. So no, there is no risk for super high weight loss with this operation.
Wait, Francois, it was not excess weight loss, it was excess BMI loss.
Which is exactly the same mathematically.
No, it's not the same. Excess weight loss is very...
You'll do the math.
Let me answer it. Because excess weight loss depends on the initial BMI a lot. If you have, let's say, 30 kilograms too much weight and you lose 15 kilograms, then you have a 50% excess weight loss. But it's a totally different with excess BMI loss.
With all my respect, they'll do the math and they will check. But I can tell you this is exactly mathematically the same. So, but my point is that, no, just to say that, it's not a stupid operation.
No.
I'm just, it's my turn. So, it's not nothing. It is thinking that having this part
we are
of
just confirming.
Sorry?
We just say, okay.
Okay.
We didn't interrupt you.
No, the thing is that having this part of the bowel without any food in it, it's strange, you know, it's a strange thing. So what Santoro did, he tried to do something for the long-term safety. Maybe he's wrong. Maybe there is other drawbacks, but there is an idea behind. And my point is that what I can tell you is, from the French perspective, never a study went so fast, widely in all the centers. It's more than 20 centers. We did a meeting with all the, the first year for the feedback of the centers with Santoro in Lille. We did that in Lille. Everyone was very happy, very happy. Not difficult. The feedback was very good. Second thing is that safety base, we don't see much more difficulties. So for you, I would be cautious and I would expect a little bit more before I throw that away. I think it's interesting and it can be a good startup. But okay, time has changed, we have another big landscape to be in, so it's different. One last thing, where you're right, it's about absorption. There is one thing that this ileal operation will make, and I know that by experience after decades, is that by a kidney stone. This is something very specific, and this operation is bringing kidney stone problem. Kidney stones. Okay. This is something. Any operation, ileal surgery, will bring kidney stones. It looks okay in the first years, kidney stone. But what I've seen after decades of another operation, long time ago, is nephrolithiasis, is nephrocalcinosis, is end-stage renal failure. It's renal transplantation. That appears 25. That's the point I would be careful of. But beside that, I think we need to wait a little bit more. I hope for the French study that Robert Caiazzo is leading will maybe answer some of these questions. But be careful. This startup is not just to throw away. Be careful.
Okay.
As I said, when there are no facts, experts are many. I apologize for my fact checker who's giving you editorial comment as well. So, but now you have time to rebut.
If I can have a question for Gerhard, but also for Kelvin. Are in your country introducing the concept of bipartition? Are you talking in your society or no? Or is because in Italy we are introducing in any case the concept. Of course, we don't practice again it.
As far as I know, in my country, nobody is doing it. I think you could only do it, of course, under an ethics committee protocol, and I think that's mandatory. And I would strongly suggest to do it with a registry, because what we see now is this real loss of patients in the midterm and long term. The operation is now around for more than 20 years, and we still have no solid 3-year data. And this is something which is really a pity.
Any questions from the audience?
And what about US, Kelvin?
I'm sorry?
What about US? Are you introducing the concept of bipartition or not?
Well, you know, I tell you, things change slowly, and even the adoption of the SADI operation, duodenal switch, is very low, and the need is not there. So adding yet another operation with unknown long-term results, that sort of thing, is really outside the norm for us.
Okay.
Again, Gerhard, I need to say something about this issue. Bipartition, the fundamentals is not having restriction and not having malabsorption. And this is something that in Brazil is very commended, and in Brazil there are dozens of units doing bipartition. They don't publish because it was authorized by the Federal Council. It was just recently open. Now they are doing that, and the data will appear soon. And they comment about this, that we shouldn't talk about malabsorption as a mechanism because it is a complication. We want an ileal stimulation, incretinic, bile acids increase, microbiota changes, and so on, to heal the disease, obesity, and the complications. And indeed, bipartition is not a malabsorptive surgery. Do you know why? Because Santoro, as Torres e Pernauti, they evaluated the surgery. And you are commenting about the old versions of the surgery. It was like I was commenting and criticizing Andres by the first version of 200 centimeters of common limb. It's not fair.
But Rui, he never published the update with the longer common channel. He just mentioned in 2020 that he changed it for 3 times, but he never updated his series. Correct me if I'm wrong.
No, it's true. He began with 150.
I can only talk about what he published.
And now the common channel is 250 plus 50 of
it's more like a SASI, and so I think it was fair enough.
Like a SASI of 3 centimeters, but you have the other pseudo-alimentary limbs. All the limbs are alimentary, so that's why the malnutrition is less. So, and indeed, in my practice, I'm doing under ethics committee authorization. I'm not having malnutrition with this operation, okay? With SASI, yes, we had some cases because it's more aggressive. I suppose it's because we have more bile in the stomach, and somehow bile stimulates the propulsion in the intestine, and the food is not so digested because of the quick entry. So in the end, just to say that it's not so variable surgery. There are data from Cadier that show that the flux division is 80% to the ileal and about 20 to the duodenum. And Vitor Dib has also the same data. We are going to publish it soon. So, but last comment, also with Roux-en-Y, there is a variability. Look how many versions of Roux-en-Y are there. Micro-pouches we bring from our president. Long pouches, long limbs, biliopancreatic limbs, 40 centimeters. So variability is in all surgeries. This has it also. Yeah.
Okay.
Thank you.
Yes, I would like to thank Professor Prager for his great speech. But when I try to understand my colleagues, when I look up the chair, a great team is told making speeches. But in the field, when we consider our patients, we have to think about every patient, primary patient, as an candidate to a revisional surgery. And when we think about study as surgery, great results, when we compare with transit bipartition, when revision is needed, a revisional surgery will be much easier to perform after transit bipartition. And in the field, I try to understand my colleagues who support transit bipartition. It makes a choice for them to make a revisional surgery easier. And maybe it reflects to the literature, the revisional rates are high after transit bipartition, because when they think something goes wrong, it's easy to change the lengths of the limbs, maybe make a narrow anastomose, and it reflects the literature, I think. I wonder about your comment on this.
My first comment would be when you design a new operation, your main goal is not to make it easy for revision, number one. Number two, we have no idea about the real revision rate after transit bipartition and SASI worldwide because we don't even have solid 3-year data. So I can't answer that question. Nobody can answer that.
May I give a small answer to Rui? Rui, we have to say one thing, that when we consider the measurement of small bowel regarding Roux-en-Y or ORGB, we consider some parameters: sex, body mass index, choice of the surgeons, and so on. In this case, we have a question mark more, in my personal opinion, that we don't know if the intake goes entirely in the small bowel or part of it in duodenum. So we have a question mark more, in my personal opinion, than in the other operation. Yeah.
I think and the percentage changes over time.
Yeah. Microphone. I'm going to push back a little bit.
That's a very good.
I'm going to push back a little bit, and we're going to one more comment, then we have to move on. Okay.
In the last consensus of bipartition in Strasbourg last July, that was a very good question. And there was a debate if you should keep the fixed length for the common limb or a percentage. Yeah. And the final conclusion, no, it won't be none of this one. It will be a range. So between 250 and 350 of common limb is enough, considering the variable that you commented very well. So depending on the profile of the patient, we can go from 250 to 350. Yeah. 350 is much more safe about nutritional issues, for sure. But that's the better rule, because the other one has some food inside, so it's the minimum to have safety about diarrhea mainly.
But Rui, on which evidence is this consensus based?
It's based in the practice of the ones that have more experience, only by now.
It's based on eminence,
yes.
And not on evidence.
No, it's based in author
interpretation
of data.
Time out.
Of course, randomized trials will come later on,
all right,
maybe 5 years later.
All right, thank you very much. I'm afraid.
So we are moving to the last topic. It's my pleasure to present Christine Estier, who is going to defend and present the endoscopic sleeve gastroplasty. Christine.
Amador, thank you. Hi, sharks. You look better than on the picture, I have to say. And I want to begin to agree with Gerhard. Too much of a good thing may turn out bad. I'm so happy that I may talk about a gentle procedure, the most gentle one here, about ESG. My shark, by the way, is also the nicest. This is my conflict of interest statement. And this is the evolution of the tool we are talking. It was a revolution. I remember exactly when I heard about the possibility of endoluminal suturing. Incredible. You saw it was bulky in the beginning. It developed over a scope with 2 channels to the actual prototype. And this tool, this device, enables to do endoluminal suturing. That's incredible. Of course, there was a procedure that has to be developed, and this procedure was endoscopic sleeve gastroplasty. It was a primary procedure competing, of course, trying to compete with surgery. And in the beginning, it was thought that this is mimicking sleeve gastrectomy. But, of course, this is wrong. It turned out very quickly that ESG is not a sleeve without surgery, because it works very differently. It is a gastric remodeling, and of course, we influence the volume of the stomach, we reduce it, and this signaling is transferred to the brain, and the brain is the one that signals satiety, hunger, and appetite. So we produce earlier fullness, but it's not the same like sleeve gastrectomy, of course. We know, in contrary to sleeve gastrectomy, that this procedure is emptying slower, is a bit of an advantage because of absorption in the duodenum, as you all know. We know that this procedure does not produce reflux, which is very often the case of the sleeve gastrectomy, very often. We have evidence on that, and I will demonstrate you that. And it should look like you see on the picture. That sutures should interlock like a French braid, because it was always the question about sustainability. And this question is right. We have to discuss sustainability, definitely, and maybe we also need an evolution of the technique, but this seems to be a very good one when the sutures are interlocking, and per definition, you have to know endoscopy is repeatable, and repeatability creates sustainability, definitely. Where does it stay? It stays here at the same level, normally for obesity grade 1 and 2, but we also decided that it may be applied in obesity grade 3 if the patient is not eligible, most often reason, or doesn't want surgery. And this is the procedure, and this, I want to show you this because this is a very holistic view of it. You'll see from the outside and from the inside, you have the laparoscopic view and the endoluminal view, and this is really a holistic view, and you see that this is really transmural suturing. This is really folding in the greater curve and reducing gastric volume. I think we can go on here. We have nowadays more than 40,000 procedures globally, and of course 40,000 procedures create evidence. We have evidence. 1B evidence. We even have 1A evidence because we have a meta-analysis on this, a real meta-analysis with RCTs. And we know it's repeatable, and I already told you that repeatability is really a point for sustainability if you do it again. We have, Gonzalo Lopez Nava was writing on this, we know we can repeat this, and we have relatively long-term data. These are the 5-year data of Reem Sharaya, but she already is about to publish the 10-year data. We have guidelines on this. There was, at the beginning, the Brazilian consensus. There is the IFSO WGO guidelines. There is the IFSO consensus, and so on and so on. We do really have guidelines. And as I said, it's for class 1 and class 2 obesity, but also for class 3 if not eligible or patient does not wish. And IFSO, I really have to thank IFSO. IFSO was so future-directed because they picked up also adolescents with class 2 obesity. And I think this is the right way. So ESG helps with NAFLD, ESG helps with metabolic syndrome. These are meta-analyses. These are not one publication. These are meta-analyses. But we know that if we combine it with medication, it's even better. The question is only when do we have to start with medication? Do we have to give medication from the beginning or when this procedure plateaus? But what is really new? What is really new? This is the Shark Tank. We have to talk about innovation, don't we? New is that we add not medication, but we add fundal mucosa ablation. And this is really interesting because it is an easy thing to do. You have a special probe for that. You need that if you don't do it with this probe, but you do it with APC. It's a little bit dangerous at the fundus. There are studies, there are ongoing studies, and look at that. The Italian study brought out 27.2 total body weight loss. This is a number, I can tell you. This is really a number, but this is new. We have to see what is coming. And most of you experienced the time when open surgery turned into laparoscopic surgery. In my opinion, really, I think now, in the near future, surgery will go endoluminal. Let's see with the new robots. So let me really take together endoscopic sleeve gastroplasty is transformative. It is endoluminal surgery. It's a new approach. It's innovative. This innovation met obesity care. This innovation will evolve because this is evolution of technique. We can supplement it with drugs. We can supplement it with GMA. And that's it. Thank you very much. Sharp.
Okay. Dr. Hamilufti, please.
All right, this has been too friendly. And you know, you speak so well, I'm convinced. It's hard to be, I don't see anyone speak better than you, Christine.
Thank you.
All right, so this is supposed to be Shark Tank and this is supposed to be business. So as a businessman, I will tell you a few things. for me to buy this, right? You showed me.
I won't sell it to you.
6-month data and 12-month data. I saw Gerhard smiling because he gets hurt when we look at 6 months and 12 months. So it's this data is very, very hard to make anything out of. You also, everyone here talks about combination therapy. You showed suturing the stomach, then burning the stomach, then giving people medication on top of all that. And we keep forgetting, at least in the US, I'm talking, someone has to pay for this. So combination therapy is great, but let me tell you in the cardiology literature, because everyone likes to show this beautiful thing of lifestyle, endoscopy, and now medication and surgery. If you look at cardiology, you really cannot compare, because deploying a stent in the coronary artery, and allowing blood flow, you either deploy it or you don't deploy it.
Yeah.
Once you deploy it, blood will go and people are happy, at least for a while, right? So here, the problem is that you're selling something that doesn't work well, is really short term, is hard to reproduce, is cumbersome. And what bothers me the most is I am one of those who investigated gastric plication. And you've heard that many times at debate. So now we're trying to do poorly performed plication, knowing plication never worked. And we still know that when we revised gastric bypass in the session with Calvin and Gerhard yesterday in the revision room, when we reduced the pouch surgically, surgically is much better than endoscopically. We all know, at least technically, you can do
Much
it.
better.
No,
Are you sure?
But just 1 second. What I'm saying is, if we staple a pouch and make it half, that other half is gone, gone to pathology. So endoscopically tries to mimic surgery. And we know the long-term data, we saw yesterday, the 3 years data, almost always after furthering the restriction is going to be back. So my problem as someone evaluating this is, like I said, sustainability, reproducibility, and particularly having to burn it now and to give medication and put duct tape around it and barbed wire is just too much. When the alternative sleeve, and I know some people do not want to have bariatric surgery, and that's the only one thing that I like. The only one thing that I like is breaks barriers. But I don't see this outside. Of course, it's owned by a company, so it's pushed more. But let me remind everyone, the landmark studies and papers, most of them are written by people who are paid consultant for the company. So we have to think the average endoscopist, not you, Christine, someone like me, just average, suturing the stomach without any landmark, putting a bunch of sutures, and letting the patient go.
It's like a duodenal anastomosis?
Say that again?
It's like a duodenal anastomosis?
But the
for an average surgeon?
the duodenal anastomosis is done relatively at the end of the anastomosis. If it doesn't leak, it's an anastomosis. Those sutures are all over the place. Thank you.
Rami, you're my friend, you know that. It was your president, I love it. Wasn't it your president who cut down the price for the drugs in the US? It was your president. So what you maybe didn't see is that I had literature for individualization of therapy, and I really think this is necessary. There was big fights about how long should be a common channel here in hypoabsorptive, malabsorptive, restrictive, what do I know procedures. I think we have to really look to the individual patient and see what this patient needs. And for that individualization, for the wish of the patient, for maybe for the patient being afraid of big surgery, I think this is really, really optimal. And as I said, per definition, you can repeat endoscopy, and this repeatability really creates sustainability. And you're right, there are costs with that, that's true, but you know, also stapler are very costly, aren't they?
Right, I agree with you. Surgery is not cheap, but when you say repeat, now you're telling the patient, you're gonna come every 3 years, every 5 years, and you're gonna keep doing this for it to work, right? So let's ask people here in the audience who believes outside the experts who are proctors and they've done a lot, who believe in this operation, who can tell a patient if we do this 5 to 10 years, there's a good chance, more than 50% chance of that weight loss to be there. Who believes that?
But Rami, this is exactly the same as if you would ask on a congress for surgeons, general surgeons, vascular surgeons, whatever, do you think you can do a BPD? It would be exactly the same question. These are all bariatric surgeons.
Let me ask you, how about this? I come to you, and I'm the patient, because that's very fair. I come to you, and I will ask you, okay, doctor, I want something that has a good chance, because we have weight recurrence after all surgeries. I agree, but now there's medication and there's surgery, and this is kind of in the middle, right? And I pay in cash, okay, which in America is not common. So most people
It's not common in my practice at all.
Okay, so in the US, it's not common, so people have been paying cash for ESG. So when they pay cash, they want to know, the long term.
Yeah.
Knowing that surgery has recurrence, so before you fire back at this, if I tell you, I'm interested, but what are my chances at 5 to 10 years? Because sleeve has decent chance.
Completely agree, yeah.
Yeah, so I'm not 100% against surgery. I'm a patient. I'd rather not have surgery. But if I'm gonna pay $5,000 to $10,000, I'm asking you, what are my chances, doctor, at 5 to 10 years to have that weight loss be relatively sustained? I'm asking you, an endoscopist.
Yes, but this question, thank you very much, this is very important, because I don't sell cars, I don't sell health, I really have a look at the patient and give him, if I think an operation, a surgery would be better, I really would tell that to the patient, definitely, believe me. I don't sell cars.
So this patient has a car already, so not interested.
You always can have a second one.
But this patient, BMI 42,
yeah.
High blood pressure,
yeah.
Virgin abdomen,
yes.
Hesitant about surgery because everyone doesn't like to have an operation, and asking you, what are my chances?
Endoscopy.
What are my chances at 5 to 10 years before I pay $8,000 because I'm middle class? What are my chances to have sustained weight loss at 5 to 10 years?
Well, I would really answer, I don't know. I don't know what is the chance with surgery. I don't know what is the chance with endoscopy. I would answer, I don't know.
But Rami, you are the patient. You don't have BMI 42. You have 32, and you don't want to undergo surgery. You see? So I have to help Christine. I mean, you have 32, and maybe you don't qualify in your insurance program for surgery. Maybe you want to have a less invasive procedure, and the MERIT trial data show 13.7% total weight loss after 5 years. So this is the answer to your question.
No, I agree. Thank you. The problem, Gerhard, is the trials were done by very, very experienced people. In Chicago, we're seeing, we have a lot of people, GI people, and that's my worry. And of course, I'm making dramatic so people laugh and have fun. But in Chicago, Gerhard, we get so many people, well, not so many, but we get a few, and we scope them, and there are sutures all over the place. And yesterday, actually, I was with Marina, right? I was with Marina having lunch, and a friend of mine who's chair of surgery at a big hospital called me. He said, I want your recommendation. A GI group
I agree.
is applying for endoscopic suturing privilege. They don't have dietitian, they don't have anything. So we are in chaos today, and that's my job today for fun, is to bring all the drama and all the caution, but I love the idea, of course. I wouldn't buy it as the investor, but let's see. Go ahead.
Mission accomplished.
Oh, is it first to the
No, the bad guy. Yeah, please.
I'll be quick. I'll be quick because I think Christina did a wonderful job. I'm the fact checker. I'm just trying to put facts on the table. So the claim was reasonable, but the evidence was very good. The claim was reasonable in terms of weight loss, but the evidence is Lancet randomized trial.
But it's not true. He's right. The evidence is good.
Well, it's Lancet. It has been reviewed. Okay, maybe it can be criticized, but I'm an investor. I'm listening to a storytelling from a young investigator trying to selling something. So, okay, for the fact, the claim is reasonable. Okay, evidence is there. But then I need the storytelling and I need plausibility. Because if you don't explain things, people don't buy it. And my point, I have just one fact, because Abu Sayed did that also. You claim that this operation is a gastric emptying slowing. That's a strange concept. In my world of bariatric surgery, everything is rapidly emptying the stomach, and that's provoking GLP-1 postprandial thing, which is important. That's why drugs are also working. So why is this concept? First, what is the evidence, real direct evidence, that there is slowing of gastric emptying, and what does it good? Tell me.
The evidence indeed is the scintigraphic measurement, absolutely, and it is good for really for the duodenum, for the absorption. That's the most important thing. And the second most important thing is that the longer nutrition stays in the stomach, the longer is you have satiety. So this is the timely distance between two meals.
This is an Australian story about the band, long time ago. You know, all the other surgery put the food in the bowel very quick.
Yeah.
So I'm just
but it did
worried
work,
about that.
didn't it? The band worked, didn't it?
Yeah, but it has disappeared because
It
it's
has
not a good way.
disappeared because of the long term.
It's not a physiological thing.
Yeah.
It's just you are fasting people. Yeah. But it's just not what we see. Okay, but I'm done.
Ricardo, please.
Yes, I agree with Garrett completely because it's a different indication. You don't have this for a BMI 31, 32. You don't want medication, so you get these procedures. Endoscopic, it works, and it's without complications almost. And about the sutures, they are lying there, as Rami was saying. We see this by all patients. The sutures are not there to stay. What is staying is that the glue of the stomach together, and we have these structures of tubular stomach during 10 years. But the sutures, they are almost gone. So don't try your endoscopies to see, oh, this is a ruin this, because it's an interpretation.
I think so. One of the big advantages of endoscopic bariatric therapies is to intervene so early in the development of obesity, yes, to intervene earlier in the development of obesity. And I think it is the right way to compare it to other endoscopic bariatric therapies like balloons. And here I see so big advantage of the endoscopic sleeve gastroplasty. And in my center, we are also big hernia center. And for example, for these patients, you have not a lot of possibilities, and ESG is really an enrichment. So I think the concurrence will be the medication, and there are a lot of non-responder or not willing for medication. And here I see a great possibility from the ESG.
You're winning, Christine. Look at that. You're so charming. Everyone is on your side. No one likes me.
Please go ahead.
And you know, Rami, this Dr. House was especially for you.
I would like to thank Dr. Stier. As we talked yesterday, I wonder, in general surgery, when we put sutures, we take care of anatomy so much not to damage anywhere. You put during this sleeve gastroplasty, you put full thickness sutures. And in this age, after COVID disease and widely use of GLP-1 analogs, we see fibrosis and tissue and adhesions so much around gastric tissue. Don't you ever feel doubt around gastric tissue, stomach? Don't you feel ever doubt when putting every suture,
I do a lot.
damaging an adjacent organ?
I do a lot. I doubt a lot. I always question everything. Absolutely, yes, always.
Hello, how are you? I am from Iran. We are very experienced with gastric plication conversion with the very, very difficult situation with fibrosis and thickening, very, very thickening of the wall of the stomach in the conversion. And it's my experience, it's the hardest word for conversion. What is your experience about the conversion?
With conversion, it's not a problem. You know, the peristalsis of the stomach is extremely strong. If you imagine, you really could swallow standing head, on your head, feet up, really strong. And this peristalsis makes, after a while, that all the anchors are subserosal. You can see them. And if you do a sleeve gastrectomy, for example, and you put in the bushi, the sutures, the anchors of the sutures are on the side you would resect, definitely, and you see them. Absolutely. To do a bypass is no problem. I did revisions of this in my former hospital, I would say in 4 cases, not much more, but it was not a problem at all.
Merci.
Christy.
Last question, please.
Hey.
Okay. I love your work, but still, I'm not convinced about the ESG because we published in 2016 in the obesity surgery our results for plication, and we did like a huge series at that time after Talipur, 2012. We did like 200 cases of plication, and the results at the initial first year and second year were good, and then by the 4th year, when we published on 2016, we had lots of recurrence of weight, lots of complication. Plus, you said that sleeve has more reflux compared to ESG. That's because of the technique of the ESG and the technique all over the world about the sleeve. We are working in the last 3 or 4 years about how to make sleeve less refluxogenic.
Yes.
Yeah, because we are studying right now all the anatomical elements of the stomach and the techniques that was deployed in the last 20 years for sleeve. And we found out that if you change the technique of doing the sleeve itself, you will have better results for weight loss, less reflux, and with the new medications, you won't need anything more, even with huge BMIs. So I think that the same that applied to plication, because it was very poor operation, is right. We should apply it to a very expensive operation like ESG, and we should compare it in this kind of thinking because it's the same.
I completely agree. And of course, there will be an evolution with this procedure, definitely. You know, this procedure is not very much acknowledged. If you look around here, these are all surgeons taking care that surgery stays with surgeons. So there is a need, there's much more need for patronizing this and democratizing this procedure. But of course, we have to look what future will bring. I completely agree, yes, but there will be an evolution.
Thank you.
Okay, so thank you very much to
Thank
everything.
you.
Okay, thank you all the audience, thank you all the participants, thank you the fact checker for this great job, and hope you have enjoyed the session. Thanks so much.